Morning, everybody.
Good
Nice to
evening.
see you all. Morning for us, for Kelsey and I. Cathy will be here soon.
Hi, Mary.
Hello, Alison. Good to see you. How are things up your way?
Busy, 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 busy.
You've been doing lots, I see, on social media.
I don't think I've ever been so happy to get to end of a month.
Really? Yes, we wonder why we do it to ourselves sometimes, don't we?
We certainly do. If anybody wants to have information for their patients on concussion, I got 3 presentations. Happy to send them links.
There you go. That's something good to know for people in the room. Alison's got some amazing information for people who are, yeah, I saw those coming up and I thought, wow, you're a font of wonderful information and so happy to share it. There's Alison doing work on concussion. All right, so we're just waiting for Cathy Boyce. She was just having a little bit of trouble with the link. So the idea of today's session is just I've got Kelsea Green, speech pathologist, here with us, and Cathy's going to join us, oral health therapist. And we're just going to talk about all things sizing a munchie. And it's very, very open to questions and conversations. And it's very, we don't have a set structure to this. We've just got some ideas we'll share from our experiences. And then we're very open to others sharing theirs or asking questions. So I'll monitor the chat. I guess that's what I'll do.
Nice to see some familiar names all popping up. It's been a while since I've been on a call.
So who's in the room today? Anyone want to say hi? We've got a mixture of people, I'm sure. I know some of those names. Dental, chiro, lots of different people. Are you recognising any speechy names there,
I was
Kelsey?
about to say hi, Michelle. I'll write back to your email today.
There you go. Anyone got any burning questions they want to start with? Chiro, of course. Thanks, Alison. Yes. And we're going to start doing some of these panels as our certified calls between now and the end of the year, bringing on a couple of different practitioners to have conversations around different things. And we threw this one a bit further open than the certified community, just because we thought it's super relevant to anyone who's ever going to use a Myo Munchee. How do you size one well, and what are you thinking about when you're doing that? Because like most things with Myo Munchee, they seem simple, but they're quite hard. Pediatric dentist from India. Hello, Krishna. Nice to have you here. I met up with a dentist from India last Thursday, actually, in Sydney, which was great. And I hear Myo Munchees are very hard to get into India, which is disappointing. So I'm sorry they're so hard to get into your country. Oralologist, dental hygienist. Hello, Geraldine. Yes, great. Good to have you here. All right. All right, we might as well just start, I guess, and just wait for Cathy to jump in. So Kelsey works a lot with speech. Do you want to talk about some from your perspective, Kelsey, for a start? Because we're all different. I'm chiropractic, so my outcomes I'm thinking about. Let's start by just talking about what we're looking for. As a speech pathologist, some of your aims and goals in what you're looking for will determine the sizing. That's always something to think about.
Yeah, no, definitely. So yeah, I think I am a speech pathologist. My caseload is only orofacial myology these days, and I have been with the Munchee team for quite a few years now. But so the way I size a Munchee, I do think has evolved big time over the years. I think we all have. And yeah, coming down to, I always come back when I'm doing supervision or in these discussions, it comes back to that individual child, like it all should. I guess it is a pretty universal tool, but we have to think about those goals that you are working on with them at the time. If I'm talking more generalist speech pathology and not just in my orofacial myology clinic, I find it can fit really well with our clients that have a lot of goals across a lot of areas of speech pathology, and doing a targeted orofacial myology course at that time isn't possible, or their priorities are in different areas at that time. So with those clients where they are more complex and they've got more things going on, just figuring out what exactly those goals are for them that we're working on. I think one of my big things often with more complex kids is to size down than sizing up, because I find they can tolerate it better. So just a real little quick tidbit there is just that's one thing I often will do. And getting them used to a smaller appliance I find more effective than often their age. I don't even these days bother stocking anything other than BBs and minis, because the kids that are seeing me are pretty much going to be mini sized, even if they are 10. Like they're in my office for a reason. And that was something I found very interesting. So we're going off not just the ages and stages of the munchies, but actually measuring that canine width. Is that where you want me to take it, Mary? Or
Yeah, no, great. Just and I thought I probably should. I noticed Cathy's now joined us, which is great. Come and say hi, Cathy.
Well, I'd love to say hello and look at you, but I can't even get my camera to work. This is the most bizarre thing.
You can rely on it, can't you?
Using the camera all morning, and now I don't know what's going on. You know what I'm going to do? I'm going to shut down the computer, and then I'm going to start again, because I'm just about. You can see. Well, no, you can't see.
There's something there, but it's not
pulling
you.
my hair out, but you'll see what I'm talking about later on. I'll be back in a minute. I'm so sorry.
Okay, you're right. That's fine. No problem. I thought I might as well start by looking at a sizing kit box and talking about what that's about and what we've got in the sizing kit box. So the idea is with the sizing kit box, for those of you who may not have seen one, we have these coloured devices which are sample only. They're actually not the colour of that device, because that is a food safe dye, not a medical. We haven't had a biocompatibility tested to be able to be our products, because they are FDI certified class 1 medical device. So these are food safe and they're totally safe for using. But and the idea of having one of these in your practice is that you can then get very confident with this sizing, because as Kelsea said, she's learned a lot about sizing. I've learned a lot about sizing, and it really is really interesting as you go along. It's not as simple as it seems. And getting the size right really depends on what you're trying to achieve with the person in front of you. And the guidelines we've put together in our sizing kit box are on an ideal bite situation. We're looking at what ideal would look like. So a lot of the time, as Kelsea said, a mini, even though we'd love to see a 4-year-old moving up to a junior, is not going to happen most of the time now. So we really need to be aware of that. And that's the biggest thing we want to probably talk about today, is probably that mini junior time. And as a chiropractor, when I'm working, I'm thinking neurosensory, I'm thinking getting that integration of the chew, swallow, breathe functionality. I won't be necessarily looking at tooth arrangement relationships and jaw growth, but I'll be looking at those very functional aspects. And so the biggest thing we're looking at is making sure they're functioning optimally, getting the lips together comfortably around that so they can nasal breathe, making sure it's not too overwhelming. And so even though they might be a 5 or 6-year-old, if they're really underdeveloped or they're really got a chronic mouth breathing issue, they're going to struggle to put a bigger device in. And so sometimes you want to start with a smaller device and then move up. That's the other thing I find with the mini junior situation, is you want the child to be happy to engage with it. And it'll be very overwhelming for, as I say, for a child who's been mouth breathing or who's really underdeveloped, to try and fit that in and manage it well. Sometimes they'll fit it in there, but actually there's no way they can access the chewing function to work well with it. So that's sort of where I think a lot of the time that is experience that you'll start to see. And that's where having a sizing kit is invaluable, because you can pull that device out and you can get the child to put it in, or an adult. We'll also talk about sizing adults as well. And you can see how are they coping with that size, and is that going to be something that they're going to be able to access function So that's something that I think is really important, is what's the goal of the person in front of you, and don't hesitate to suggest that you may need a transition. Start with this one that's manageable and they can use really well, but knowing that eventually you want them in the optimal sized one for their growth and development moving along. So in my practice, I don't want a 6-year-old staying on that. That is not going to allow optimum growth and development for a 6-year-old's jaws. And it's not designed to go back far enough to cover the 6-year-old molars. You really want the next size up to be getting that proper activation of all the jaw for where the teeth are going to land, and you want those little back plates, the little back plates at the back of the munchie. You want those covering those back molars. And Cathy will talk a little bit more when she comes on, because she's dental in her background, so she can talk a little bit more about the teeth and how they relate to it all. She's going to try again. We'll see how she goes this time. But
Well, yeah, even on that, Mary, like the other day, I have a little girl. I think she's 3.5, almost 4, and so I prescribed a mini for her, but she was really struggling on it, gagging. We just weren't making any progress with her tolerance of a munchie, and I've actually taken her back to a BB, but obviously it's not as chewable for particularly a 4-year-old's jaw. So we were using it passively, but she's at least accepting it, tolerating it, building up that passive use of the munchie. And she does have a teeny tiny mouth. Her parents, I actually originally thought she's fitting a baby. But the parents are like, no, but she's this age, like we don't want to have to buy multiple. But then they actually have seen the benefits already. And she has a class 3, so she sits back. And so I was wanting her to just have that feeling and that neurological wake up to where her jaws are in space while she sits passively in the munchie. So and that's been really effective. Obviously it's not my long term. I want her back in her mini and up to a junior, but it was a good place to work on that tolerance and compliance with it.
And that's great. Let's talk about that. That's right, the BB. Cathy, are you in the room now? Let's just say hi to Cathy.
I sure am.
There she is. Hallelujah.
Apologies, everybody.
No, it's all right. We're
I've arrived. My pulse can now go back.
So we'll just continue that conversation around the BB there for a moment, because it's a great point, Kelsey. Yes, you can use the BB, but the BB is not designed to cope with big chompy teeth from 2 years of age up. And so a 4-year-old, as Kelsey said, useful tool for oral, for passive use, and for getting that oral posture and awareness, neurosensory. That's what a lot of it's about. But yes, you'd have to get the parent aware that is not the tool for them to move forward. And sometimes they do just need to understand we have to get them accepting and integrating with it, because a lot of people will just go automatically, oh, I want the bigger size because I know it'll last longer. And that's good in theory, but we have to be able to get them off the ground for a start. And so that's a really good point of what you're talking about, that you've started with the mini and you can see she can engage with that. And then eventually, once she's got some functional work happening, she'll be able to move up.
Yeah, definitely.
So Cathy, we were chatting about, so I was just talking about mini junior is a common one to get the sizing right on, and I was just talking about those back plates covering the back teeth that are erupting, different things. I thought it'd be great for you to jump in from your dental experience and perspective and talk a little bit about how you size and what you do around that transition sort of age and stage.
Okay, yeah. What I think is really interesting, and yes, coming from a dental perspective, we look at where the teeth are currently, where they're going to be erupting. Why have I just gone off?
You have.
I do, yeah. I don't know why. But anyway, I think I'm going to be back any minute.
We can still hear you.
Yeah, anyway, so while the camera's waking up again. So what I need to, when you are looking at a child's growth chart or growth perspective, we're not getting the same. It's not like every 6-year-old is going to be the same size. Dentally, they're not the same level of, what would you call it, progression. You can have a 6-year-old who's still dentally only 4, and you can have a 6-year-old who is dentally, their dental age is around about 8. And it really just does depend on the level of, that's the genetic side of things generally. It's not about the size of the jaw, it's where the teeth are at. And this is for how many teeth are coming in. So when you've got those little pads at the back, sometimes you can have a child, and I'm really sorry, but my camera is just like turning in circles, Mary.
Don't worry, we can hear you. It's all good.
Okay, so when you've got a child who is, say, has a very wide palate, and they might be still only 6 or 7, to put them in something that would be normally that age may not be the best for them. So have a look at, we do measure the intercanine width, which is great. But if you've got an intercanine width that doesn't fit the traditional age of, say, a junior, and this is what I have experienced even in my own kids, grandchildren, the age was 7.5, but the width of the palate still needed a Myo Munchee because there was some habits that were forming that were actually, the mandible was sort of being, what would you call it? Well, what we call retrognathistically placed. It was this little kid, this little boy had developed a reading habit, ferocious reading habit. As soon as he was able to start reading, then reading chapter books, he read like there was no tomorrow. But his head was forward and his jaw then was not, it went, rotated down and dropped down and rotated back. And so therefore he was developing a lip trap habit and also a class, very much a class 2, what we call like an overjet. And so we needed to help the mandible to be able to come forward. So whilst he was reading his books, then he used the Munchee, and it really exercised the correct posture of the mandible. And that's what we were using it for. Now, he was not going to fit in, or the junior was not going to be the most appropriate size. So I upped him to a tween at that age, because that was the most appropriate size for him. But those little resting pads, I might call them, or that are on the Myo Munchee, which I'm holding up now and you can't see, they were way too big, and they would have gone way too far back in his jaw and would have been super uncomfortable, and he wouldn't have worn them. So because that was meant to be able to cope with these 12-year-old molars, which was still not going to be for about 5 years on average down the track, seeing he was only 7. I took them off. So I adapted the size of the Myo Munchee, and this is what I do often with kids who are, not quite the right fit. You often have to adapt the Myo Munchee to fit, to make them fit for purpose, I guess you would say. And so by just trimming off the back part, and then you'd have to trim off, just round out some of the edge, because you're getting the back of the Myo Munchee. You're just making it, retrofitting it, I suppose you would say. You're retrofitting it. And that makes it acceptable, and it makes it comfortable for the kids to use, because what you want is comfort. And if the classic sizing is not going to be appropriate, then you are able to adapt the Myo Munchee to fit the kiddo. I always give them time, and I always listen to when I try Munchee in, and the kids will use it for a little while, and particularly when the parents are reporting that they're not using it because it's hurting them. Now, oftentimes the parents will dismiss the fact that it is it's hurting them, because they'll say, well, how can it be hurting you? It's all soft and it's made of, silicone, and it can't be hurting you. But when you're dealing with children, if you cannot get the level of comfort that they are happy with, then they will perceive it as hurting. They won't say, oh, it's rubbing on the gum in a little tiny place here, or down here, it's annoying me. The most common thing that I probably get is right down in the back, in the groove, what we call the buccal groove, at the back of the cheek, almost like at the end of the row of teeth. That often has the Myo Munchee kind of rubbing into the gum there. If the munchie is just a little bit maybe too large, not too large overall, but just for that child. So by cutting or trimming a millimetre off, that can make a huge difference. And the same with when you have a Myo Munchee that is, you've got somebody with a very narrow palate, and so up behind the front teeth, it's almost like more in a V shape, or getting close to a V shape. What happens is the I guess you would call it the bunching up of all of the silicone, and particularly the little rubber. I hate calling them prongs, Mary, because when you're talking to children about prongs, it means, so the little rubber, I call them massages.
Massages, nice, I like it.
The gum massages. Okay.
Oh, yeah, perfect.
So if they're all bunched up, that can actually really irritate the palate. So there's nothing wrong with getting your little nail scissors and trimming back the little massages in that area, if that makes. And sometimes you just need to take, a couple of rows off. And that means that the kiddo is really comfortable. So thanks, Mary, for showing that.
There are the massages. I love that, the gum massages. Perfect. They feel so good. But yeah, that's great info there from Cathy. And I think that's exactly right. Having the confidence to trim them a little bit and make them comfortable for, as you say, the kids, because they won't exactly know where or what the problem is. It just, they won't want to do it because it does irritate something. And so being aware of that, and those of us who don't work dentally, we're often a little less aware of that. So that's great, Cathy, that you're able to describe that a bit for us, especially up in that inside arch, as you say. If there's a lot of, if it's very narrow and they're getting extra pressure in there, that can make a huge difference. If we trim just a couple of those little prongs off on the inside, for those of you who aren't dental, that's what she's talking about, that inside arch. And also, don't be afraid if that whole piece is rubbing up against the palate, to trim that down a little bit too. So there's a real variety. Yeah, go, Kelsea.
See, Brooke's question here was actually what I was about to add, and Cathy touched on it, is those kids with the overjet and even open bites and all the different malocclusions going on. So what about the teeth that are out on an angle? So I'm guessing that's more that overjet, and yet we would size up for those. Even what I usually do, like even if the intercanine width is small, you are trying to fit those other teeth. And always, even especially for modifying or cutting them down, preparing the family for, they're really far from ideal right now. The tool needs to be modified. They're going to probably wear this out quickly. If we definitely have to use it properly, but it will wear because they're not in the ideal, and that's why they need this device. I think that's a big discussion I have with my families. And so the wear from a child with really long canines or the overjet, so I find they'll pierce through, or I have to size up to a tween or a junior so that their teeth actually fit in, because they're wanting to go over the munchie. I had a little guy that's been using his munchie from prescribed somewhere else, and he's come to me and he had the whole munchie in his mouth. So his lips were closing around the stick, but the whole entire munchie was within behind the teeth. And I was like, no one had told them the teeth should be in that bit, so they didn't actually, I didn't even know how, it was too small. Ultimately, it was too small. But
I think
that's a great point. Just make sure when you've got them there, have a feel, because yes, every now and then you do get, and you're like, oh, it's gone into their mouth, but actually it's no way landed with the jaws, the teeth into the
Yeah.
arch forms. And that's once again this opportunity to use a sizing kit to enable you. And as you go along, you will get more confident and understand the ones that, okay, they just need to go up a bit and we're going to trim a bit off the back.
Mm.
They can cope with them when there's, as you said, those different teeth in different places than they ought to be. Cathy,
Yeah.
you're going to respond there too?
I was going to say that is why it's so important if you are issuing or recommending munchies that the parents are really well educated in actually, and if you can watch the children as they're beginning to explore the munchies so that they are munching correctly. And I always say when I'm talking to clinicians and to parents too, that the munchie is not meant to be chewed in the traditional breakdown food kind of thing. And I use the word munching because I want them to not masticate it to death. And most of our kiddos have got dysfunctional chewing patterns anyway, unless you're just getting them very early and you're introducing them to the world of mastication and chewing properly. But for the older ones, they've already developed a dysfunctional pattern. And so you don't want that to transfer to the munchie. So if you can get them to learn how to bilaterally munch on their munchie, so they're actually doing that with the correct, jaw position and using their molars, I think that's one of the most important things to encourage. Now everybody's, this is where I'm coming from, because I'm coming from, the dental perspective, because I want that kind of thing. But really everybody, Mary, you would want that correct position and munching action for your clients. And the same with Kelsey, because it is where oftentimes, say in speech, Kelsey, you often have kids that have developed a dysfunctional mandibular posture with their chewing and their speech to help, get their tongue, especially if they're tongue-tied, because their jaw is helping the tongue get where it needs to go. So we need to get that reestablish that correct patterning, and then that can transfer into food.
Yeah. And even, that whole focusing on those back munches. So adding on to Brooke's question too, is like, so even if those teeth are, because you're a speechy there, Brooke, teeth are on an angle and out, we're sizing up so it fits in, but then also talking to them, it could be an issue when they're chewing, if they're chewing at the front of their mouth. We actually, when we're not chewing, we're munching the munchie. It's talking to them about those back teeth. Munching, and then I think it wouldn't be as much of an issue. It isn't as much of an issue when they've got a significant overjet. There was also just another question about lip closure, which I think is a pretty what we're talking about here too. And I think lip closures are really hard, and there's something I had a little one. I know it, but I had a little one just recently. Had quite significant buccal ties and lip tie. Had a munchie about a year. They bought it online and then they found me, but he could not close his lips. And I was like, well, that makes sense. Like the mum's like, I think it's too big and all these theories. And I was like, well, actually these ties were so uncomfortable on where it was sitting, so he wouldn't bring his lips closed. So that was just like, something. It wasn't too big. It wasn't necessarily too small. It just was like, hey, we've got pressure points happening here.
Yeah.
So being aware of
what
that
did you
individual.
do there, Kelsey? Did you trim some? Because you can trim, if you're dealing with that, you can trim sections away so that it doesn't push up as strongly.
Yeah, we actually did
what
size up a little bit and trimmed it, but because they were happy to buy a new one. He'd also pretty much chewed through the original one because of the incorrect use. Like they didn't know much about it. They had just bought online. So it was, we sized up and he sat and used it passively as well, just to get used to it. So often kids, if they just go straight to that munching, and again, they're not in the ideal occlusion and the munchie is ideal, that they'll have those pressure points. They'll have that sizing difficulty unless they're using it passively and sort of preparing their mouths for it. seeing so many of these mouth breathers with such poor oral hygiene. So like their gums are sensitive. You're putting a silicone thing against those gums, they're going to resist it. Or the teeth falling out. That's what I'm dealing with at the moment. Oh my clients' teeth keep falling out. And then that's a different, like sizing it up based on, I've got wobbly teeth. The wobbly teeth mode is such a challenging one. I'm like, oh, you have to use your molars. It's a great time actually to promote the molar munching.
That's another point, that the kids often complain that the munchie is hurting. They don't even realize sometimes that they're getting a wobbly tooth and it's becoming mobile, because it's only that they might be subconsciously not eating on that side because of the wobbly tooth, but they don't realize. They just, their brain just goes, oh, look, that's a bit sore over there, so eat on the other side. So when you're putting a munchie in and they're trying to do that bilateral thing, it hurts. And that's because they're actually, when a tooth is wobbly, of course, when you're putting pressure on it, it's going to be jamming down into the gum. And sometimes I think the best thing to do is go, if it's wobbly enough, to just say, have a break from your munchie and get that tooth, wobble it like crazy and get it out yourself. Put $10 on top of the fridge, I often say to the parents. It's amazing if you can put $10 on top of the fridge, and by the time that tooth is out, it comes out really fast. That little bit of motivation.
That's great.
But well, I used to say that when I was in the, working in the dental clinic, if the kids didn't want their tooth out, I said, oh, this is the cheapest option, like if it was getting really loose and causing them pain. But I just sort of say, have a break, wiggle that tooth out like crazy, then get back into it. Sometimes that is, at least that means that you're listening to the child. And I think that that's a key, because as a practitioner, you want to make everything possible for the children. Kelsey, when you were talking about ties and getting comfort and getting lips together, I find the kiddos that have got a lower lip tie find it really difficult to get that extension of the lip over and to get to the handles. So that's where I will make a little bit of a trim on the munchie to accommodate that as well. Like all of those.
That's in a vertical height, Cathy?
So what I'll do is I'll do like a crescent shape off the bottom. I wish I could show you.
Yeah, that's right. We'll show for you.
So it's just I just say start with 1 millimeter, to the parents. And get the scissors, or else I can do it, in the clinic. And you just take a very small amount first. And sometimes, you'll go, you put that back in. How's it feel? And they go, it's getting better, And the next 0.5 millimeter or 1 millimeter would be, they go, oh, that's great. And then you've got that to move forward with.
Yeah, it's a good point. Just go very small amounts, because once you've cut it, you can't go back.
Yeah.
And Brooks just asked another question there around, is there any part of the munchie you shouldn't trim? So the arch form, as long as you can maintain the arch form, you'll generally be fine. You can trim a little bit off most places, but you want to make sure you've still got integrity of the arch form, so that it will hold into the molars. So you can trim sections at the front, but don't trim too much off the arch form at the back. So it'll stay into the molars, because you can still chew there. But if you need to trim sections off around the front or inside, as Cathy said, with the prongs, you can definitely do that. But just go tiny amounts first, and then just see what's comfortable. And don't do it straight away either. Often just getting it in, and it'll be like, oh, just getting used to it. And actually it'll settle in quite fine. It's when it persists for a week or two, then you're like, oh, okay, there is a spot. And it's not uncommon, because the jaws aren't in perfect shape. They're often, got all these misalignments and different things going on. So sometimes we do have to do little trims. And the other one I'll just jump in on there was the client who can achieve lip closure, the one that Kelsey talked to about the buccal ties, just to sort of as a general thing.
Yeah.
you really do want those lips closed around it. That's really an essential piece. So the other thing you can do if you've got those kids with those big class 2 overbites where the teeth are coming right out the front, big overjet, you can trim a piece of the device away so the lips can come down, because you want that lip activation to be what's going to create ultimately the sorry, just trying to let someone in. Yeah, you want the lips engaged and the lips to be there. So if they really are struggling with a big overjet forward and they can't get the lips around the teeth and the device, that's my thinking on that, is to make it so they can get that lip down.
I was like, and I think it is a mixture of exactly what you've said, Claire, like stretch to close and then relax it over time, or relax muscle. Like it's sort of all of it. Like I would bring them back to passively using it and just focusing on whichever lip isn't engaging, like which is usually the upper lip in the kids I work with. They'll be able to, force lip closure with the mentalis, but not with the upper lip. And so just getting them to start engaging that, dropping it down, and it could come from relaxing, stretching, but also engagement and strengthening of these muscles of the upper lip, because don't usually use them. They're just, everything's coming usually from the bottom in a lot of my kids. I don't see their lip closure even at rest. I would even be checking on that if their lip closure at rest is just coming from the lower lip and the mentalis. That is often the case, I see.
That's
great
information. Yep, go.
Sorry, I keep on putting my hand up and you can't see it. If I can sort of also add to that, when you have a kid with a significant overjet, it's not always that the front teeth are way far forward. It's a combination usually of the front teeth at the top might be, moved out a little bit, as it flared out a little bit, but the mandible is often retruded. So that is why it's really interesting to see how, when they seat the mandible, the top teeth and the bottom teeth inside that those channels of the Myo Munchee, it often becomes challenging for them to use their back teeth because they're using muscles that they just haven't done. But the positioning and the ease of them being able to obtain lip closure is significantly easier. But that is a time thing. And I'm working with a little one at the moment who is in that same position, and we've been working very much on allowing her. She's up to like her 10 minutes using the munchie, but her jaw is being positioned forward. Okay, she's 6. So we're not actually growing the jaw or anything like that, but you are actually positioning the jaw in a more natural position than what it was when it was, in inverted commas, naturally hanging backwards for her. And so what you're doing there is you're actually working on the ligaments and the muscles and everything that have not been engaged. And she was reporting quite a bit of muscle, not so much tension, but exhaustion when she was using the munchie. And that's because she was actually working those muscles forward as she was, using the munchie. And what that has transitioned to in this little one is now the difference. She's not had any orthodontic work or anything like that. And we're not talking about moving teeth. She's now chewing her food. So the difference in her being able to exercise those muscles in a correct function using the Myo Munchee and bringing the mandible forward means that she's now able to do that with food. So now she's actually can breathe while she's munching, because she gets the mandible and the tongue out of the airway. So she's now transferred that over to food. So her appetite has increased, her digestion has improved, and she's not getting tummy aches anymore when she's eating her food. And the other thing too is that she's on the spectrum, this little girl, but she is now eating such a wide variety of foods because can hold things in her mouth and chew them properly, that her interest in food is increased, and she's now exploring all different kinds of foods. And this has only been a matter of months. So I think that, using that munchie and then using it correctly, and just being aware that it's not always just the front teeth that are out of alignment. We've got to encourage the muscular from the lower mandible to come forward. And this is where I think, when you're sizing the munchie, just be aware that what you're trying to achieve from your own perspective, of course, with using the munchie. So if you had looked at her and put her in and upsized her just to fit those front teeth in, and gone way bigger, I think that probably would have meant that the jaw would have had to come far too forward. Okay, if you understand what I'm talking about. So, I kept her. She was in a junior. She was 6, and that'll see her, for quite some time. But it's been a really lovely experience because you begin to have all of those other aspects coming out, and I think it's really important to make sure that you ask parents questions like that. How's her food going? How's their eating going? When you're, doing their reviews, because you see all those little amazing payoffs. But she was one that we really we started slow and got into it. And then she became, very proficient at it. And it's great. It's only been a couple of months. So, I just think, be mindful of where the jaw is sitting. Okay.
Yeah, that's a really important one for those of us who are not dentally trained specifically and are working in this space and wanting to prescribe munchies. Is they are a very good generic tool and great for us to be able to utilize. But yeah, really, that's where, and as I say, that's where the sizing box comes in really well, because when you put that in, it'll tell you a whole lot of stuff. You'll look at it and you look at how the child is in it, and you're like, oh, okay. There's more going on there than you kind of realize. And if you start to see that they're struggling with their nasal breathing, that's the first bit. Do not get them to chew if they can't keep their lips gently closed around that. That passive use is so helpful anyway. So they want to jump straight into chewing, but don't start there. Start with the nasal breathing and having them just manage their lips together, having it comfortable. That's probably the most important bit, is to get the right size that they can start to manage that bit. Now, I'm just noticing Doris has had a hand up for a while. Doris, jump on in. What did you want to say or ask?
I just wanted, from an orthodontic standpoint, I worked for 34 years with an orthodontist. I'm a dental hygienist, a myofunctional therapist, and a buteyko breathing educator. Actually, having somebody who is retrognathic, they don't have enough lower jaw, and forcing that lower jaw forward into a Myo Munchee is a really good thing, because it stimulates growth of the jaw. That's where the growth occurs, is at the condyles, is right at the top of the condyle. So when a child has their jaw forward, it is stimulating growth. And then, of course, the chewing action that we have in the Myo Munchee, which is what everybody does, that's also making the buccinator muscles and the masseter muscles bulkier, which makes the bone grow bigger. That's Wolff's Law. So it's not a bad thing to have a kid who's retrognathic having to slide their jaw forward to get their upper and lower teeth engaged in the Myo Munchee. So this is actually going to benefit their growth.
Yeah, beautiful. Thank you, Doris. It's so true. You'll see massive change just by getting that oral rest posture into a better place. And then once you've got that, if you can activate that chewing, you will see phenomenal change with how that jaw will start to grow. Yeah, thank you for that perspective, Doris. Yeah, absolutely. Now, we got any more questions in there at the moment? I'll just quickly touch on the fact that the junior and the tween, so they're quite different in their design. The junior has extra millimeters in the bite plate because it's all that mixed dentition that's a bit all over the shop. So that's why that's designed that way. It's kind of got extra hardy because that's what we were finding with that age group. They're the most likely to break the device. So that's a bulkier, sturdier device. And for those who work with special needs or any of that kind of thing, that'll be a much hardier device than, say, the tween, even though the tween age group wise, we say is from, 8 up. It's sort of, and small adults, it's a much smaller dimension device. So the bite plate on it is quite thin compared to the junior. So this is really a small adult. We've kind of made this more like the adult. So if you've got dentition that is all over the place or a lot of malocclusion kind of stuff going on, the junior is a way better option than the tween. But as Cathy said, with a narrow arch retrognathic 7-year-old, the tween can be perfect. So it's kind of having a little look at those devices and seeing who's in your practice and what you're trying to achieve with them, because they can be another one we tried to make them as covering all the different needs of what we're trying to achieve, because then this one here is super relevant. It goes back far enough for the 12-year-old molars, super relevant for small women. You would never put a big teenage boy in one of those. You're going to put them into the adult. Okay, so the adult is a much sturdier device again. So the tween it has a much smaller vertical height than the adult. So for those people you can see are very small in their mouth, they may not be able to get their lips together around the adult. They're very narrow and just smaller dimension people. A tween is good for them. In an ideal world, you'd like all your adults in an adult. We'd like all adults to be chewing adults, but sometimes you need to transition from a tween for a small dimension person who's going to struggle for a start because their mouth breathing, they've got all that same stuff we talked about with the younger ones. But eventually, you'd like to get them to the point where they can manage an adult by getting that system more functional. But
and like even just personally, if I'm writing reports, I have my tween in. So like if I'm using it passively and it's just in my mouth for sort of like the rest posture, it's tween. But if I want my exercise and I'm getting a munch going, I get out my adult. So like, and that's me personally, but when I work with adults, I'm like, you can, and smaller women, it's like, well, you have to go back to what your goals are. So when my goals are just like my rest posture and not to clench down and to bring my jaw in the right position while I'm writing a report or getting stressed, I will use my tween just to be sitting there. But yeah, I definitely feel like when I've got the adult in, I have to work harder.
Yeah.
For those, like, to be working on my functional goals. So yeah.
Yeah, perfect. That's exactly right. It's it is interesting. That's right. What you're trying to achieve at the time. So
and I think sizing wise, sorry, but trying them yourself, I think even that experiencing that difference in like, oh, when I have a bigger one, I feel like this. When I have a smaller one, I feel like this, for your own learning is really powerful. Like we talk about it with parents, having your own is great to be able to show them what you're doing, and as a clinician to experience it, but even being able to try the different sizes and how your body feels when you've got a bigger one in versus a smaller one, I think is really powerful when you're sizing, because it doesn't have to be super complex to size them up either. And I think that's
it becomes quite intuitive once you're used to it, but these are just things to think about. That's why we thought, well, come on and just do a call around this kind of work, because it does. Once you've started working with them, it just is very intuitive and you know what you're doing. But if you're sort of new to it, or if you're not fully versed in all the myofunctional side of things, you have a little bit of understanding around it, you can see the benefits. I would highly recommend getting a sizing kit in your practice so that you can just get that confidence. I think there are and then you'll go, try it. Yeah, great. I was on the mark. And once you start to get that confidence, it makes a big difference then. And you want to get it right. If you're going to refer someone to go and buy one, or they're going to buy one, you want to make sure it's the right one for them, because if it is a child with a junior and they're not managing it, then that will put them right off wanting to use it. So yeah. All right. Any
Just had a
last
quick question talking about
Yeah.
transition, when to transit to proper size or next size. Hard to be specific on that one, but
Yeah. Once again, it's the goals, what you're trying to achieve and within your practice. So if you're like for Kelsey, speech pathology, she's got certain goals she's trying to achieve in that arena. That child may then go on to be seeing a dental practitioner, and they'll probably use a size up to be trying to achieve their dental outcomes. That's, and for example.
Yeah, but I mean, it just meant I would transition them up when basically when you think they're ready for it. And that sometimes is look, sometimes if I start a client on one that I know that they can cope with, you know, like you said, Kelsey, when I first joined, you started that little one on in the BB, I think it was, before you transfer them to the junior. Well, sometimes I will put a kiddo that has had no idea of how to breathe through their nose, how they've maybe just had their tonsils and adenoids out, they don't have the confidence on nasal breathing. I'll put them in something like maybe a mini to start with, okay? And then I'll say, as soon as they're really confident with this, because they have been airway protective for a long time. So kids who have to be mouth breathers for whatever reason, usually for obstructions or they've had tongue ties or something like that, that they have to be a mouth breather. The brain has not, given them the confidence that you can have the tonsils out or have that addressed and you can automatically make the switch. They will have that airway protective gaggy kind of reflex, and that has to be undone. So by putting an appropriately sized Myo Munchee in there straight away can really be very confronting, and it will be like, get out of my space, because this is an airway protective reflex, I call it. Now, once they know that they can breathe, that they can chew, they can swallow with that in, then you have license to introduce them then to the next size up, which might be the most appropriate. And that sometimes can be just like maybe 6 months or so. Now, if you explain that to the parents, that this is where you're going with that, the fact that you're upsizing them within 6 months or 12 months or whatever, 12 months is usually, okay, it's accepted. But in 6 months, people go, oh, I've just paid for a Myo Munchee, now it doesn't fit. Well, it's like a pair of shoes, you have to keep on, reassessing the size. And when they're ready, nobody goes to the shoe shop and goes, well, I'm sorry, but, they're now a size 9, but we've only got size 6 available. We'll just have to use that. Okay. So it's about just meeting them where they're at. But the thing is, what you've done is you've gained so much confidence in that kiddo that they will transfer quite well. Now, the beautiful thing is if they're the eldest child and they've got some younger ones following up, I just say, and look, just like a pair of shoes, you can do a hand-me-down, just give it a big boil up, and then and you can, and the younger ones come up and coming, and it just sort of makes more sense. And a lot of people, don't realize that they can be, handed down if they've not been destroyed and they're past their use by date, especially if it's only 6 months old.
It's a good point. They should last really well, and yes, just boil it up and hand it down the line. That's exactly right.
And Fran, that is often a barrier, is that parents just not wanting to purchase another one and being very financially, so they're like, oh no, we'll buy the bigger one, because they'll grow into it. And it's like, well, it's not. And you just have to come back to those goals and what that child needs, and also be like, how exciting will it be when they're actually at that next stage? Like that shows us progress. And we want them to be in that next size up, but it's almost like a graduation ceremony. Get them up there. Right. Also, they're more affordable than, long-term orthodontics and things. That's how I got my brother to use it.
Promise that though, Kelsey.
Yeah,
we don't go there, but we we know that, yes. And surgery for grommets and ENT and all the other things that
Yeah,
the
because when
benefit.
they've got their chewing and swallowing stuff organized, their rate of ear infections just dives completely. And that is often, you know, when you start bringing those benefits of correct chewing and swallowing. And I think it's really important to talk to parents about the benefits of this oral exercise, you know, tool, rather than, and I know, Erica, I think you had a really good name for it, because when I was on a call with Erica and we were saying, I don't talk about it being a device, because if devices are often, we're in our world, in our dental world, okay, see, Kelsey's got a different, you know, mode of care, but in the dental world, if you're using a device, it's meant to actually do something, like move teeth or you know, reposition things, whereas this is an oral exerciser. And what did you call, when you were talking, I think it was you, Erica, that had another name for it, which was fitted really well in.
She's trying to remember.
Yes.
I don't remember exactly, but I know it was therapeutic something. I wish I could remember now.
Yeah, I wish you could remember too, Erica.
Yeah,
it was
well,
like a therapeutic, you know, tool or something like that. And I think that's wherever you're coming from. Remember that the goal is to promote correct oral function and establish correct chewing, swallowing, breathing coordination. And if you explain that to the parents as you're going through the journey of, you know, swapping sizes and what size you're going to introduce and why you perhaps have to, you know, start them small, they'll get it.
Yeah, I think I was just going to add one quick thing there around the space in the mouth and how it feels for the child. As you said before, Cathy, if they've been chronic mouth breathing and they've had no ability to have any space there, once you tone that system up with that correct nasal breathing and the swallowing, there is a lot more space there. Just to be aware of that too, that there will be more space, because it's quite amazing the difference it makes when you tone up a system, even if they've been swollen tonsils and things, as the tone of the pharyngeal will start to hold things back and the soft palate starts to elevate and activate. It does make more space and they will be able to manage better. So that's just to quickly say that. Now we've got 2 minutes left. Any other questions? That's Alison saying, got to go. Francesca just saying yes, that just getting that communication around that transition that they may.
I was going to say, I really start that early. At purchasing, I prepare them for, we will need multiple, and if we don't need multiple, then we don't need it. But it's that conversation really, really early, I think helps. Even adding in, I write reports, it's in my report. Like we're going to be prescribing or starting here, and we're aiming to get into the correct size of a junior in 6 to 12 months. Like that sort of, I try not to do it too prescriptive because then you get stuck by what you've said, but it is still setting up that timing with them.
Excellent. All right. Well, I think we're going to wind that up now. It's been great to have everybody on. Thanks for joining us.